The next R is repopulation, and we'll talk about this only very briefly. Repopulation or regeneration just means that the stem cells are multiplying and new cells are replacing the ones killed by the radiation. Late responding normal tissue don't repopulate much during treatment, but cancer cells and cells of acutely responding normal tissue proliferate while you're treating them. The faster you treat the cancer, the better. But if you treat the cancer too aggressively, if you accelerate the timeline of treatment, then you don't give cells from the acutely responding normal tissue time to repopulate. The side effects can get so bad the patient can't stand the treatment, and giving the patient time to recover allows time for the cancer cells to also repopulate. This is the biggest failure of radiotherapy, and that's why accelerated regimens are so attractive, but generally don't work. We want to reduce tumor repopulation by decreasing the total time over which radiation is delivered, but at the same time, not at the expense of the patient. The next R is reoxygenation. Oxygen plays a critical role in cell killing by radiation. Cells that are hypoxic, which means they have an inadequate oxygen supply, can be as much as 3 times more resistant to radiation than well-oxygenated cells. In tumors, hypoxic cells are cells that are further away from the blood vessels. During treatment, they can become increasingly reoxygenated and therefore progressively more radiosensitive. Let's go back and look at the oxygen enhancement ratio. The oxygen enhancement ratio is defined as the dose of radiation that produces a given biological response in the absence of oxygen divided by the dose of radiation that produces the same biological response in the presence of oxygen. This varies with dose and can be seen in the survival curves for aerobic or oxygenated and anoxic or oxygenless systems. Why does this effect occur? Well, the 2 most widely accepted hypotheses for the oxygen effect are that free radicals caused when radiation interacts with water in the cell may be enhanced by the presence of oxygen, or that these chemical changes may be reversible when oxygen is not present. Other theories are still emerging though. Richardson and Harper in 2016 hypothesized that radiation can cause the emission of reactive oxygen species from the mitochondria, which increases the oxygen effect. Either way, oxygen is a powerful radiosensitizer of cells. As we've seen, the oxygen enhancement ratio varies with dose, as can be seen in the survival curves here. Aerobic or oxygenated and anoxic or oxygenless systems are contrasted, and the oxygen enhancement ratio goes from 2.2 at lower doses to 2.7 at higher doses. Whether the oxygen effect is caused by not fixing damaged cells or is caused by increasing free radicals, the oxygen effect is related to the repair of cells. Recall, beta-type damage is the damage that occurs by 2 strands of the DNA at different times from different particles. By reducing the likelihood of repair, you can enhance this beta-type damage. At lower doses, alpha-type damage dominates, so the oxygen enhancement ratio is smaller. Furthermore, high LET radiation causes predominantly alpha-type damage, and there isn't any oxygen effect observed for high LET radiation damage. This can be seen in the comparisons of the oxygen effect for X-rays, neutrons, and alpha particle irradiation. So how does this affect radiotherapy? Well, if it takes 3 times more radiation to kill hypoxic cells, then these cells are less likely to be killed during the radio treatment and are a major cause of regrowth after therapy. Now, there are both acute and chronic hypoxic cells in the tumour. Acute hypoxia occurs when the tumour squeezes the blood vessels and cuts off the blood supply. Then, when the tumour shrinks, they open back up again. Chronic hypoxia is due to the diffusion of oxygen through tissue. If the distance from the blood vessel to the cancer cell is too large, then the oxygen can't reach them and they can remain hypoxic for a very long time after treatment. So upon radiation, a number of things can happen in terms of the hypoxic cells. There may be a sudden reoxygenation of some of the acutely hypoxic cells because the blood vessels will open and blood and oxygen can flow to these cells. There is a slower component to reoxygenation, which consists of the chronic hypoxic cells finding themselves closer to the blood vessels as the tumour shrinks. Also, revascularization has been observed that might also reoxygenate these previously chronic hypoxic cells. With each treatment, therefore, the oxygenated cells are more likely to die, and the time must be given between each treatment for more of the hypoxic cells to become oxygenated.